Looking hopeful. Yeah.
Can you see?
Gotcha.
Lovely. Very good. So, as I say, I am a surgeon in training, so this will be a little bit surgeon orientated, but as a lot of our work that we did was a lot of kind of surgical related stuff. Again, please chip in, ask any questions if you want to go along, or I've got a couple of kind of our papers to share with you, so maybe we could even ask questions after each of the sections if that would be easier, or whatever way. As I say, I'm happy just to have a chat about it, really. As I've kind of already said who I am and what we've done. The main work that we undertook was really looking obviously at the NELA data set from a kind of surgical slant, but really about how we could improve training and trying to identify kind of modifiable kind of service provision factors, which I'll kind of explain a little bit more as we go on. The first thing I'd like just to speak to you about was within elective surgery. I'm sure, as you all know, working in theatres and intensive care, etc., general surgeons, we tend to have an elective special interest. So, you know, colorectal surgery, breast surgery, etc., etc. And over the last 20 years in elective general surgery, there definitely has been a shift to formalise that within training. For our CCT, you still are CCT'd in general surgery, but you do declare a special interest now. However, within the curriculum, all general surgical trainees are required by the end of CCT to be able to prove that they can manage an unselected general surgical take. So basically what that means is that whatever comes in, you know, through ED, etc., that if you're the person on for the night as the consultant, that you will be able to manage that without having to call for help. However, what we don't know is that does, you know, the special interest of the consultant surgeon who is responsible for a patient's care who's having an emergency laparotomy, does that impact on their post-operative outcomes? So the first thing that we did was we had the data from years 1 to 3, and we basically divided the patients into two specific groups. So there was patients who had an emergency laparotomy and then a colorectal procedure, and we defined colorectal procedure as basically anything in the large intestine, so right hemi, left hemi, Hartmann's, panprocto, subtotal, etc. And those were the colorectal procedural group. And then there was an upper GI procedural group. So those were anybody who had a perforated peptic ulcer, oversewing of a bleeding ulcer, a distal gastrectomy, or any kind of gastric surgery. And those were the upper GI group. Then what we did was to find the consultant surgeon special interest. Again, I'm not sure how familiar you all are with the NELA data set, but whenever both consultant surgeons and consultant anaesthetists are entered onto the database, the GMC numbers put in, and for surgeons, the special interest is inputted. I'm not exactly sure how many consultant surgeons actually realise this, but it's this a special interest that is, they declare, or their hospital deems them as. So if they work as a colorectal surgeon, they're put down as a colorectal surgeon. So we basically defined what their special interest was, and defined both HPB and OG surgeons as upper GI as a whole. And then we had OG surgeons and HPB surgeons, upper GI, colorectal surgeons, and then breast, vascular, EGS, and general surgeons as well. So as you can see from this graph, this one on the left demonstrates the colorectal procedures that were performed. In the colorectal subspecialty group, there was just under 25,000 patients in that analysis, whereas the upper GI group was smaller, and there was just over 5,000 patients in that analysis. I'm sure you guys will see, appreciate as well, working on the front line, that there definitely is more emergency laparotomies performed for colorectal procedures probably than upper GI cases at the moment. As you can see from figure 1 here, the majority of the colorectal procedures were performed / supervised by a consultant with a special interest in colorectal surgery. And similarly again in the upper GI group, but still a lot more of the OG surgeons were involved in their care. I think, again, from being on the front line, I think we'd have a lot more colorectal surgeons within the workforce, so that's perhaps not unsurprising. So the primary outcome for this study was all-cause post-operative 30-day mortality, and that was defined using the ONS mortality statistics, which has been, externally linked with the NELA dataset. We also looked at return to theatre in both of these procedural groups, and also length of stay post-operatively. So what we performed was an adjusted logistic regression analysis for both of the procedural groups for the outcomes of mortality and return to theatre, and then we performed a Poisson regression for the length of stay analysis. So the things that we adjusted for were age of the patient, ASA grade, Pre-Operative mortality score, because we only included Pre-Operative mortality because of the collinearity of the morbidity score. We also adjusted for the grade of the surgeon and the anaesthetist, and whether they were admitted to CCU or a level 3 bed post-operatively. So what this first table demonstrates, this is the colorectal procedural group. So as you can see here, this is the adjusted, so they're basically the multivariate regression analysis results. And this suggests that if you have an emergency laparotomy in this country and you need to have a colorectal procedure done, and your operation is not supervised or performed by a consultant surgeon with a specialist interest in colorectal surgery, there is a 23% increased odds risk of death. And again, I sound like I'm speaking to an audience that know what they're talking about, but as you can see, the confidence interval doesn't cross 1, so obviously that's a statistically significant result. Similarly, in the return to theatre analysis, again, if your procedure is not done by a colorectal surgeon, there's a significant increase in return to theatre, and similarly for your length of stay as well. Again, a similar kind of pattern seen in the upper GI procedural group. Again, a statistically significant increased risk of death if your operation is not performed by an upper GI surgeon. However, the return to theatre and length of stay, was non-significant for return to theatre, but actually a slightly lower length of stay in the upper GI group. I think things that when we were thinking about why that probably could be, it may be that the colorectal surgeons were left to do the easier operations, or perhaps they bailed out in them sooner if they're more crumbly, and then they said, okay, well, you can go home to be palliated or things like that. But that's something that we obviously can't give a full answer for. I think this is an interesting paper for kind of the surgical community, really, in terms of how we are going to manage things going forward. I'm probably not familiar enough with how anaesthesia and intensive care works in terms of your guys' subspecialities, but you wouldn't normally say that you were, a thoracic anaesthetist, would you specifically? Or, I guess it depends on which hospital you work in, maybe in tertiary centres perhaps. But for us, while this may seem like it's stating the obvious, if you have a colorectal operation that's done by a colorectal surgeon, you're obviously going to do better post-operatively. But the thing about it is, it's how we actually implement this nationwide, in that, in big centres, in the East Midlands, we run a speciality on call, but there's 4 or 5 other hospitals around in the region that don't run a speciality on call because they've only got 7 consultants in the area. So for us, that's something that needs to be thought about at a more maybe a national level. But if I'm honest, I can't see how in every region we're going to start running a kind of hub and spoke model for general surgery, because I think there would be uproar, if I'm honest. But something to think about, really.
Anna, can I ask so you mentioned about EGS as a specialty in itself. Yeah. Where would they fit in? Are they predominantly colorectal, or is it completely separate?
So it's an evolving and a very, very new kind of specialty, Matt. And it's, at the moment, it's quite unclear how these types of people will impact on these outcomes. They were included in the non-specialist group. So if they'd coded themselves or been coded as EGS, they were included in non-colorectal. I think it's going to be very interesting. And there's definitely a lot more jobs, new colorectal or new kind of surgeons who are becoming EGS surgeons. And I think perhaps repeating this analysis in maybe a couple of years' time, whenever you have more data, will be interesting to see how EGS surgeons fare. I think there will be, I think it'll be interesting. I don't know how EGS is run in other hospitals, but in our big centre in the region, the EGS ones don't actually do any of the big stuff. So they have a split on call, and if a nasty Hartman's needs to be done or something, the colorectal team do it, whereas the EGS consultant just gets kind of left with the abscesses and the appendixes and things like that. So I'm not sure if actually that are going to be perhaps another difficult one to rigorously test, because again, how are you going to know what the service kind of configuration is in each trust? But good one for debate anyway. So yeah, so let's see what else we've got here. So yeah, so this one is another I again thought interesting, and this one I felt that we actually would be able to implement at the ground and then make a bit of change with this. Again, I'm sure you all can appreciate that getting patients to theatre on time is one of the biggest issues in one of their journeys. There's obviously a lot of work has been performed and done about sepsis, antibiotics, etc. And we all know that getting the antibiotics into these types of patients with sepsis from any source is the prime goal. But there has been very limited work at looking at actually the timing of source control for patients who have sepsis secondary to an intra-abdominal source. And as I said, we wanted to look at how could we, well, first of all, was there a negative outcome following that? If there was a way that we could try and improve that. So in this section, what we looked at was the cohort of patients who had had a perforated peptic ulcer. And the reason that we used that cohort as the study population was we know as surgeons that if someone has got a burst stomach ulcer, they need to go to theatre and they need an operation, they need to be washed out and a couple of drains, etc., etc. It's not a pathology or a presentation that you manage conservatively. And the aim of the game is to get them in and decontaminated. We kind of felt that was a clean group, because there should be no variation in that as compared to somebody perhaps who had a large intestinal perforation, perhaps from a diverticulitis, which can be managed conservatively initially rather than straight to theatre and then compared to the conservative ones who've had a couple of days of antibiotics and then aren't just really settling. So that's why we have used the perforated peptic ulcer cohort here. Previously, the literature, like I said, was a bit limited. It was a small study from Japan prior to this that only had about 150 patients in there. As with everything with the Japanese, they had like a rigorous protocol. Everybody had a CT scan. Everybody had these antibiotics, etc., etc. But they reported quite interesting results. That they said if their patients, so they weren't perforated peptic ulcers, they had any form of gastrointestinal perforation. But if they said that they had a 0% survival rate if patients didn't get to theatre within 6 hours, which I thought was staggering. And then there was a slightly bigger study done in Denmark, again, which was using the perforated peptic ulcer cohort. And they said that they had, per hour delay getting to theatre, there was a increased mortality risk of 2% cumulatively. There's a few things with their methodology, though, that was interesting, in that they included all patients, so not just patients who had a perforated peptic ulcer, but bleeding ones as well, and also patients who had had their operation greater than 24 hours after admission, which I think introduces another kind of layer of confounding or bias or whatever, in the fact that perhaps this patient could have been languishing on a medical ward for a couple of days and had the misdiagnosis and have, again, additional elements that we were unable to adjust for. Yeah, so what we did here, so as I say, we used perforated peptic ulcer disease. The cohort included just over 3,000, I think it's 3,923 patients. That was all patients who had mortality outcomes available and had data available for the risk-adjusted analysis. This is just a histogram to show the times from theatre. As you can see, the majority of the patients were getting to theatre between 4 and 8 hours-ish. And as they thankfully levels out a bit towards the end, which is good. This is an interesting diagram. I'll not ask you what you think it looks like, but hopefully as anaesthetist in intensive care, you probably don't see too many bits that look like this. But anyway, the reason that we did this was to ensure that there wasn't too much variation in the different timing groups. Again, I'm not so sure. This was more of an exploratory kind of graph, but I thought it was an interesting one. Within the NELA data set, one of the things we do is we can divide the patients into what time they came into hospital. I'm sure as you all saw several years ago, time of the day you came in, week of the day you came in, does that make a difference? But anyway, so these are Valin plots, and they basically show the distribution around the groups and where they're all kind of focused. But what this figure shows is that, not unexpectedly, it obviously takes longer to get the patients to hospital if they came in the night, and also that there's more variation in the group that came in from 6 o'clock onwards. Again, I don't know what your guys' experience would be, but I find that probably fits in with what happens around the world, around the UK at least. So yeah, similarly to the previous study, as I say, we used mortality as our main outcome. And by the time we did this analysis, we had the 90-day mortality available for analysis, which is good. Because I know Matt's obviously done a bit of work on longer term outcomes following emergency laparotomy. But I think a 90-day mortality is a bit more informative about longer term outcomes for these patients. And what we did, as I say, was used time from admission to time into theatre to calculate a time in hours. So we used a continuous variable as our main independent variable of investigation, and then again performed a risk adjusted analysis looking at what was the impact on mortality. So this table 2, as it says there, demonstrates that for every hour increase after admission to theatre, or admission, excuse me, I've actually done a night shift, so I'm sorry. For every hour after admission that a patient arrives in theatre, there's a 4% cumulative increase in death, and that's in anybody, regardless of their physiology, regardless of their preoperative blood cells, etc., which I thought was pretty impressive. And then what we did was looked at their preoperative physiology. So essentially, well, you guys know a lot more about preoperative physiology than me, but the sicker ones, in a simple surgical way, the sicker ones. So we defined, shock as a tachycardia and a hypotension. And for those patients, there was a cumulative increase of 6% per hour by the time they arrived in theatre, which again, I thought was interesting. So, somebody who doesn't get to theatre for 6 hours following admission, they've got a 36% increase odds of death by 90 days compared to somebody that gets there in an hour. I think if you told those to the patients, they probably would be running down themselves. But I think as well, how this is interesting is that, again, I'm not sure what happens in your guys' hospitals, but if I tried to book a lap ulcer or a perforated ulcer, they'd be like, okay, it can go next, no dramas. But if I tried to book a ruptured AAA, to me, that is the pathology that everybody drops everything, everybody comes in, the second team are in, etc. Within the literature, there hasn't been any real analysis looking at the hourly cumulative increase of risk of death in ruptured aneurysms, but their 90-day mortality within the ones that survive to get to hospital and have an operation is actually 36%. And if you look at that in table 3 down here, so the 90-day mortality for the physiologically shocked ones is 31%. So essentially, it's comparable. And I'm not saying that this is, there's obviously other bias involved, etc. And it's not a causal study, but I think that's interesting. And I think, this is the type of thing that we can be going down to ED. And, I always try, and say, the sooner we get these people better, the better it is for them. But it's just something that, we've presented this nationally, hope that people will go back and take it to their teams and actually try and get people there quickly. So yeah, so that was that one. How are we doing time? Not rambling too much. And then just a little bit about kind of trainees, a subject close to my heart, and I'm sure most of your hearts, is looking at trainees. And, especially at the moment, I'm sure you guys are finding as well with COVID and all that kind of stuff, obviously our training opportunities are somewhat depleted. So everything counts. Within obviously NELA, one of the key kind of core elements of that is promotion of consultant-led care from decision-making and pre-operative assessment all the way through the journey, which is obviously extremely important, in particular for the high-risk patients with a post-operative risk of death of greater than 5%. But what we wanted to look at with this is whether trainees who were being recorded as performing the operation on their own, so just the background to this, the definition of who most senior surgeon in theatre is that they have to be in theatre. So it doesn't mean that they have to do the operation, but they have to be there essentially supervising. So the ones that were recorded as a trainee in theatre means that it was just a trainee on their own. So what we did in this study, so we looked at all the patients who'd had emergency laparotomies, and then identified and, obviously cleaned down who had done their operation. And we divided it into two groups. So the consultant led, so the consultant present in theatre group, and then the trainee group. Again, some of the options for who did the operation in NELA includes, trust grade doctors, SAS doctors, etc. But we didn't include those doctors because, as much as I'm sure they're extremely experienced and have had lots of training, etc., they're not technically, on a recognised training programme. So the two groups were consultant-led, and they also included post-CCT fellows, because again, the definition of a post-CCT fellow is that you have the competency as to act as a day one consultant. So they were included in the consultant group, and then there was the trainees. So what have we got here? So yeah, so this is the description of the kind of two groups. So what I think is interesting here is that, so the NELA risk score, so the consultant group definitely did have slightly higher risk patients in it compared to the trainee group, probably not to be unexpected, I would have suggested. And looking at the crude figures, so before we move on to the analysis, looking at the crude figures, the post-operative 90-day mortality in the consultant group was, again, a bit higher than the trainees. Return to theatre again was higher, and length of stay was a bit higher. We then looked at within, again, in general surgical syllabus on our training level, we have to obviously log a certain number of cases. We're meant to do 100 emergency laparotomies, either with a consultant scrubbed or present or performed. And within that group of laparotomies, you have to do emergency laparotomy plus, small bowel resection, right hemicolectomy, etc. And again, there's certain numbers that you have to do for that. So what I wanted to do was analyse it by each of those kind of training categories. And again, we performed a regression analysis for the outcome of 90-day mortality. And again, what this basically analysis and slide shows, that across all of the emergency groups, that there was no increased risk of death if the operation was, again, coded or recorded, that a trainee was acting independently. So that's good for the patients, but it's also good for training. What we're not saying, I'm not saying that consultants shouldn't be there, but I think what it shows or suggests, hopefully, is that even in high risk cases, the trainees can be involved. Every opportunity should be used as a training opportunity. One of the things with return to theatre as well, we didn't really see a significant increase in the trainee group either. Obviously, this one suggests in the adhesiolysis subgroup, it suggests that actually the consultants had more return to theatres than the trainees. I think perhaps one of the reasons why perhaps the trainees patients seem to have lower mortality, as much as we adjusted, for NELA risk score, pre-operative physiology, etc. Again, within any data set, there's obviously limitations in what that data has been collected. But I think from a surgical point of view, things like previous surgeries, have they had an abdomen that's through, multiple surgeries? What's their BMI? Are they a big person? As much as BMI, technically is included in ASA grade, that technicality of having a big fat abdomen that you're having to pull and retract and you can't see anything and, it's the middle of the night. Or also things like, as I say, we've put Hartmann's procedures there. There's a great variation in the levels of difficulty of a Hartmann's procedure. It could just be a perforation sitting there and then you clip and it's out and that's grand. Or it could be one, that's stuck down in the pelvis, everything just like a bomb. So I think there is a bit of, quite a bit of unknowns in terms of the technicalities of the operations that have been performed here. But the main message for me, and I think maybe for trainees around the country, was that we're not messing it up, hopefully, which is good. So yeah, so just a final little bit was, again, this wasn't really something that I did as part of my PhD research, but with a collaborative group of anaesthetists and haematologists from Southampton and Oxford. And they are, I think they're running still a prospective arm, well, I say prospective arm, it's prospective part of this study now, about collecting a bit more real-time data on patients who are having emergency laparotomies and about their hemoglobin levels and a bit about the transfusion practices that happen around emergency laparotomies. So prior to that, they wanted to understand a little bit about what has happened previously. So we did a bit of a retrospective analysis on, again, the NELA cohort looking at anemia pre-operatively. The data on post-operative hemoglobin was very poor and not clean at all. So that's why we have analysed kind of pre-operative anemia. Excuse me. So this is just again kind of characteristics of the patients that were included. They were defined, their hemoglobin levels were defined into the anemia categories based on the World Health Organization categories. So again, I think one of the things that we'll pick up on a little bit later on is the mortality days bit down here. So when that says observed, that's what they mean by the ONS mortality rates, and the predicted mortality here is the NELA risk score. So that's just for the way the journal wanted it, we've put it in as observed and predicted rather than NELA risk score. So yeah, we'll touch on that in a little bit in a minute. And again, what we did was divided them into the groups and then performed a regression analysis using a similar methodology as you've already heard me rabbit on about, adjusting for, again, all the similar types of things. Again, shows a relatively normal distribution of the preoperative hemoglobin of patients coming in and having emergency laparotomies. Quite a few variations. Probably an important point to mention at this point is that we didn't include patients who were having bleeding pathology, so bleeding peptic ulcers weren't included, or anyone who had the indication listed for theatre as bleeding or evacuation of hematoma or anything that would have obviously caused their preoperative hemoglobin to be low from that side of things. So yeah, again, we performed a multivariate regression analysis with 90-day mortality as the main outcome. Not unsurprisingly, if you're anemic, your mortality goes up. Again, it's difficult to make direct causations again for this because, you know, it could be marker of, poor function, how sick they've been at home, are they having a cancer operation, etc. But compared to elective surgery, obviously we know that they get pre-op, prehab now, if they're anemic, they have iron infusions pre-operatively, but obviously timing is critical in these emergency patients, and there's limited scoping sometimes to tee some of them up. So yes, again, this is a 30-day mortality, which again is similar, and again return to theatre. As expected, increased risk in the severe or moderate and the severe groups. Obviously, a significant limitation of this study is that we don't know which of the patients had transfusions, if any of them had transfusions, if any of them had anemia of chronic disease beforehand. We obviously aren't able to collect specific information about, people who had, perhaps hematological conditions and things like that. But it was more done really as a kind of descriptive piece as well. What we also were able to do in this study is, I'm sure a lot of you are familiar with the NELA risk score, which was specifically formulated for emergency laparotomy patients by the team at RCS and Clinical Effective Unit. And when they performed and formulated that risk score, they used 2 years of the NELA data, and as I say, developed the model so that it would be more specific for this cohort of patients rather than using the PPOM, which hasn't been obviously formulated for them and can perhaps overestimate mortality in the more high risk groups. So what we're able to do is actually use these 4 years of patients and actually kind of essentially validate that the NELA risk model is pretty good at predicting mortality. I think initially, whenever people looked at this and saw that it said, oh, the observed mortality was 9, it was predicted, and here that it seemed that the mortality was underestimating, or the the risk model was underestimating actually what was happening, and obviously that was a concern. So that's why we put in this element of the paper, which is probably one of the most interesting parts of it now, looking back on it. I didn't think that at the time, but that's another story. So what we did was ROC curve to test the discrimination of the model, and it performed pretty well in the whole cohort with an ROC or under the curve 0.86-ish, I think. What have I written here? Yeah, 0.863 using the whole cohort, which is pretty good. And then we used Hosmolemso to test the validation. Again, I'd never seen a Givity calibration belt until this. So don't ask me too much about it because I can't be able to tell you much about it, but it was something that we put in to satisfy the editor, being honest. But essentially what it shows is that obviously you've got the expected mortality, so NELA risk score on the bottom here, and then the actual observed mortality. It should obviously represent the red line along the middle should be the ideal, and this grey line is demonstrating that's pretty good up to 60%, and then a little bit of variation, but still not too bad. So that was really an additional added bit of that paper, which was not too bad in the end. But yeah, so that was a bit of a whistle-stop tour of some stuff that we've done.